I am, like Cindy said, going to be talking to you about palliative care and nursing care, two things that are obviously very near and dear to my heart. Kind of a little bit more about me. So I started here in our cardiothoracic ICU, so hearts, lungs, the vascular system is kind of my background. And then I left and I did hospice and palliative care admissions for a while, and then decided just to kind of come back to the outpatient setting and got hooked up with the Interstitial lung disease program here and working with Dr. Fisher and a couple of other providers as well. So I like to kind of start with just a question. So palliative care, when I say that, does it bring up either A, anxiety or confusion for anybody? Okay, good. Good to know that I'll provide some good information. So I am going to kind of just hopefully lay the groundwork for what it is, what it's not, and how you get benefit from it. And I want this to be as informal as possible, so please, if you have questions, shout them out, raise your hand, whatever. So, and I promise not all my slides are this wordy, but I thought it was a really, really great definition from the World Health Organization about what palliative care is. And just kind of to essentially take a few pieces from it is that palliative care is about quality of life. And how they do that is by really great, really in-depth assessment of each patient and what their symptoms are, and then figuring out how to alleviate those and giving every patient quality of life for whatever quantity and whatever things that you're facing. And it's all encompassing. It's not just from a physical standpoint, it's also from psychosocial and spiritual as well. So kind of the initial piece, so palliative care. These are, I feel like, the big misconceptions about palliative care. It's not hospice. And one of the best things that I can use to describe it is that they are sisters, but they're not twins. So there's a lot of things that carry over into both types of care. There are philosophies of care, but they're not exactly the same. Palliative care is in no way the end. It is actually, I think, a really good way to provide hope for everybody, not only for the patients, but for caregivers and family members as well. And it's not the end of treatment. We'll kind of go through a little bit more in depth about this, but you can use palliative care while still pursuing aggressive measures for treatment for any type. So if it's scleroderma and then you have other things that obviously are a part of the autoimmune process as well, you can pursue aggressive treatments for all of the diagnoses that you have and still qualify for palliative care. So what palliative care is, a really brief summation, is it's an extra layer of support. And I think with the complex nature of what each patient has going on, the more support you can have, I think is really, really beneficial. And we want to provide you guys with the right resources to help you navigate just, like I said, the complexity of what you have going on. Just like you have a team of doctors around you probably now, this is an extension of that. So it's a team approach to help manage symptoms that are related and things that you have going on. And then, like I said before, it's used in conjunction with all of your other treatments. Just to reiterate, it's not just for the patients, it's also for the family members as well. We'll go through some of the resources that they provide for family members and caregivers so that you can kind of see some of the benefits. So how does it work? So you can get a referral from any provider. You can also do self-referrals, but essentially you have to, either your doctor's office or yourself have to make contact with the hospice and palliative care company and kind of say, hey, I'm ready and I'd like to address potentially signing on with you guys. And then what happens is the evaluation. So either a social worker or a nurse typically comes to your house so that it's convenient for you, and they will adapt to any scheduling needs that you have. And they come, and what they do essentially is they present you what it is, what services they offer. They assess you as a patient and kind of what your goals and needs are. And you still, at that point, get the ability to say yes or no. They're not used car salesmen. is another really good way of putting it, is that it's still you that's driving the decision. So even if you say, yes, I want someone to come to my house and give me a presentation about what palliative care is, you still get to say yes or no. And then if you decide yes, then you consent. So it's consent for treatment. Just like if you had a surgical procedure or anything done in the hospital, you have to give your permission for them to be a part of your team. And then it starts the planning phase of, okay, what are we going to go after? What are the things that you want from us? You get to be the captain, essentially, of this ship, and you come up with a plan of how best to use their services. And I say fluid process and not permanent, because let's say you sign on and after a few visits, you say, you know what, I'm not seeing any benefit, or there's a personality conflict, or whatever it may be. You, again, have the ability to say, this just isn't for me. And then you get to sign a piece of paper that says, I don't want to be a part of the palliative care process anymore, and they say, okay. And then 3 weeks later, a month later, 2 days later, you say, nope, that was a bad decision, or I've changed my mind, or something new has come up, and I really feel like I'm going to benefit from it. They will come right back out to your house, re-sign you up, and you can restart the process. So it's very fluid. You never have to feel trapped. If you feel like you're benefiting from it, great. If not, it's okay to say no. So the type of care that's offered. So the initial part of it is that you have a nurse practitioner or a doctor who specializes in palliative care. They come to your house usually every 3 to 4 weeks. A lot of it is really dependent on what your needs are and what your symptoms are, and you get to kind of decide those. And the beautiful thing about the people that are coming to your house is, so just like in the medical world, you have a cardiologist who's trained to take care of your heart. You have an oncologist that's trained to take care of cancer. These providers are specifically trained in palliative care. And so they have a ton of knowledge and a lot of things in their tool belt to be able to help you. And so some of the things that are kind of offered within that, you have to expect that first visit, it's going to be a little bit long, because they're going to do a full physical assessment, just like you're seeing a new doctor for the first time. They're also going to go through all of your medications. They're going to do even kind of like a little bit of a spiritual assessment. They're going to do a psychosocial assessment. How is your anxiety? How are things going with you and your family related to the diagnosis? And then they're going to go through all of the symptoms that you're having and then create the plan of, okay, how can we tackle this? How can we get you quality of life? How can we best serve you? And some of the things that they do really, really well is medication management and education, because they have the ability to sit down with you at home, and you can open up all of your pill bottles. You can bring everything out in front of them, and they can go through it one by one. Sometimes when you come to clinic, time is unfortunately sometimes an issue, whereas they don't have as many time constraints as we do in the hospital, and so it's really, really helpful. And then the biggest thing is symptom management, shortness of breath, pain, anxiety, things related to your GI tract. I mean, you name it. They are really, really good at helping you manage symptoms at home. So, which is a big thing, and it can eliminate sometimes the need for coming into the doctor's office maybe quite so often. It can also not necessarily eliminate fully, but it can make it so that you maybe don't have to come to the emergency room, or maybe you don't have to be admitted. They have the ability to kind of help manage things at home. Most organizations have a 24-hour nurse line, which I think is huge. Because even here in the hospital, sometimes, I know for any of you that work with me, sometimes it's tough. I think I've told this to some people, you get caught in the phone tree of death. Option 1 to here, option 2, and between there, sometimes you get hung up on. But you have a registered nurse who's available to you 24/7. 2 a.m. on a Saturday, you're trying to decide, okay, I've got this new symptom, or I've got a worsening symptom. Should I go to the hospital? What medication should I try? What should I do? And they can help walk you through that. And then Most companies also have a physician or a nurse practitioner who is on call. So if that nurse doesn't know the answer, they can page whoever either your primary palliative care nurse or MD or someone who's on call to help get you answers. I think that's a really big safety net for a lot of patients. They can also bring in social work. So I know social work too has some confusion around it, but they are incredibly, incredibly helpful for insurance issues, which I'm sure everyone in this room has dealt with insurance issues, whether it's related to getting payment for medications or for treatments or for oxygen. I mean, anything. It's amazing. And they are incredibly helpful at navigating those murky waters of the insurance world. They're also there for emotional support. They're phenomenal at helping manage anxiety, depression, getting the right resources to help with those symptoms. They're also really wonderful at getting community resources. Like Dr. Kolvenbach mentioned, getting hand therapy involved, physical therapy, occupational therapy, home health. I mean, you name it, a whole host of things. I know we have some patients that, getting out of the house is really, really difficult. And meal prep is incredibly difficult related to the skin tightening and some of the other things they have going on. So getting Meals on Wheels set up, to bring meals to your home that just alleviates one piece of stress that you might have. Getting someone in, I know for our patients who have interstitial lung disease, some of the simplest tasks are incredibly taxing. So taking a shower, vacuuming. Vacuuming is one of the most exhausting things that we hear from people. So getting a resource for someone to come in and help clean your house, even if it's just for an hour, something that's just really helpful to, like I said, alleviate stress, maybe alleviate body aches and pains. I mean, you name it. And then the other thing that's really wonderful is they work really, really closely with your primary team. So most of the organizations that we've worked with, if they come out and assess a patient and they think something's not going right or they have recommendations, they are either calling us or faxing us with their recommendations. They're really involved in our care. It's not that they are taking over in any way, but they are just an extension of us in the hospital and in the clinic. So a really big question, how is it covered? I know that, cost is a big thing when you're on a lot of different treatments and you have to think about, okay, we're adding something else. How do I make sure that this isn't going to, quote unquote, break the bank? So typically when you have that nurse practitioner or you have that doctor that comes to your house, typically what it is so if you have a copay for seeing your primary care, so if you have, say it's $25 to see your primary care provider, typically it will be $25 then for that nurse practitioner or that doctor to come and do an assessment. Medications, there really isn't any change as far as that goes. If they prescribe a new medication, it's going to go through the same process as it would be if your primary care provider or your rheumatologist or your, pulmonologist prescribes a medication. It's going to go through that same process and then covered in pretty much the exact same way. And most insurance companies, including Medicare and Medicaid, have either a specific arm or piece that addresses covering palliative care. And so you can typically within whether it be your coverage booklet or you can call a lot of times and find out what specific things are covered. But as a previous couple of slides back, they are really good about helping you get the services that they're recommending covered. So that's where your social work, that's where your nurse line, that's where even your nurse practitioner who's coming to your house really come in handy to make sure that, like I said, it's not an added stress of adding these services. So some of the benefits, I didn't add a lot of studies in here, but there are studies that show that patients who are involved in palliative care really from the time of even diagnosis, really early on in the beginning, throughout their disease process, it actually optimizes their treatments. they've shown to have their treatments be more effective. They tend to, for some reason, pay less out of pocket. They just have a lot of benefits, and it starts from any time that you get them involved. And they can be, like I said, involved as early as the first day that you're diagnosed. So, and any time throughout there. But optimal symptom management, like I said, they have tools in their toolbox that are amazing. I thought, when I worked in the ICU, I thought we were amazing at pain management and shortness of breath. I thought, man, we are the best. We offer the best care. We offer the best treatments. Nobody else can do anything better than us. And I went and did hospice and palliative care, and I realized how much I had to learn. And I don't exactly know how to explain it, but they are wonderful for helping manage those symptoms at home and keeping someone at home versus sending them to the emergency room or, an inpatient hospitalization, or even keeping them out of the doctor's office if needed, or recommending one of those three options, if that's where it needs to go. They really decrease stress. And I think when you have a chronic diagnosis, I think stress is a huge part of it because it's the unknown initially, and then you have a lot of other things that come up. You have a lot of other symptoms. You have sometimes overlaps of diseases, and I think that as each new thing comes up, or as a disease progresses, there's a lot of unknown and a lot of stress that comes with that. And that extra layer of support at home, I think, can really help decrease the stress level. And we know that. And I apologize, I can't remember your name, but, talking about that from diagnosis, they can pinpoint that there was a really big stress-inducing piece of their life that caused maybe the trigger in that autoimmune disease. And if we can keep stress at a minimum, I think symptoms can not necessarily go away, but they could get stable or they could improve, which I think is amazing. And then the caregiver piece of it. I know that a lot of you, there was a breakout session about how to deal with stress as a caregiver, because you want to be there. You're experiencing it with either your loved one or your family member, but you're not experiencing it in the same way. And you want to do things to help, and you want to make them better. But it can be exhausting, and it can be taxing. I know some patients, like the caregivers, when you get to a point with any disease, if you're afraid to leave them because you're not sure if something's going to happen, especially if they're in an unstable state, palliative care can set up respite care so that someone's there to either check on the patient or be there while you're gone. They can help you get services set up to help work through emotional issues, which I think that we know that everybody experiences, both the patient and the caregivers and family members. And they can also spend time with the family members, answering questions face-to-face, one-on-one, and be able to provide that extra support. And then easier navigation. I talk to people about this a lot. Navigating the healthcare system is sometimes like walking around a room blindfolded. I mean, you just have no idea what's going on. I've been a patient myself, and it's difficult. And I have the medical knowledge and the ability to do it, and it still can be frustrating. And they are, like I said, just another layer of support to help get rid of some of the barriers that are there, whether it be helping with access to care, helping coordinate things with your doctor's offices when you're having trouble getting in touch with, whoever it may be. They can kind of be your go-between, which is really helpful. And then advanced care planning. So these are difficult conversations about goals. What are your goals in your treatment, and what are your goals going forward? And it's tough to think about deciding a code status or deciding a living will or some of the other things that go along with that. But when they are really great at providing the right information and helping you even fill out forms that you need to, when you're able to make those decisions, instead of being in an emergent situation and now you're not able to make those decisions, or you're not thinking clearly and you're not able to make the decision you would if you had not waited. They're good at having those difficult conversations of, should we pursue treatment, or is it time not to? Or this is my overall goal for any treatment that I go forward with, and they will help get you through that piece. And I've kind of had said this before, they're going to help hopefully avoid ER visits and hospitalizations, which we know once again is stressful, because I've sat in the ER myself, and you sit there for hours and kind of, getting treatment going, and being in the hospital is not your natural environment, and there's tests and people and all of that goes on. And not to say that those aren't needed and essential sometimes, but if we can avoid them, I think it's really helpful. So who should use palliative care? Anyone, any patient with any chronic illness and anything that is a life-threatening illness. And like I said, it can start from the beginning of diagnosis, and they can be a part of your team throughout the entire process. And they can, like I said, it's a fluid process. They can pick up and come and go at any point. If you, like I said, you start with them and you feel like, and I don't need them yet. So fine, put them kind of on the back burner and just know that they're a resource to come in down the road. And then I did want to kind of talk just really briefly about what hospice is. Because I know, like I said, a lot of times when we say palliative care, people just kind of, they hold their breath because they assume that we're talking about hospice and that we're kind of giving up. But what hospice is just that the goals of care they've shifted a little bit. So you've decided not to pursue aggressive treatments. And the focus now is quality. And when I used to go out and visit with patients, I used to say for hospice or palliative care, it's quality for whatever quantity. It doesn't matter whether it's 2 days, 2 months, 2 years, they are there to provide quality for whatever is left. And then it's more comprehensive home care. So if you have what the initial treatment kind of looks like is you typically have a nurse that comes to your house typically 1 to 2 times per week. They can come all the way up to every day if needed. It really is just in the palliative care system, you are the captain of that ship. It's all based on your needs. It's all based on your symptoms and what you feel like you need from that team. And you also have a certified nursing assistant that comes 1 to 2 times per week and potentially every day if needed to help with all different types of things, wound care, dressing, bathing, you name it. I mean, the list is quite long. And I think one of the amazing things is that it is covered 100% by Medicare and Medicaid and most insurances. And most hospice and palliative care companies they have grants if it's not covered by your insurance to make sure that that is not something that ever has to cross the mind of any patient that's decided that hospice is the way that they need to go. And the other team members of the hospice team are a dedicated social worker that is specifically assigned to you, and or a chaplain, a psychologist, whoever may be within that company is also assigned to your team as well. And they help get set up. So if you need anything at home, your medications are delivered at home. If you need a hospital bed, if you need a wheelchair, if you need anything that you need to be at home or wherever it is that you want to be, they get that all set up for you. So it's much more robust as far as the care goes. And one thing that I should have mentioned on how it's covered as far as palliative care goes is if anybody has Kaiser offers the type of care that hospice does for palliative care. So it's one thing to really look into if that's your insurance. They have an entire section that they cover, and they cover nurse visits, they cover CNA, they cover all kinds of different things. So that's something that, if that's your insurance, it would be a good thing to really look into. So I'm going to kind of shift gears a little bit and talk a little bit about nursing care, because that's what I do. So symptom management, we're also here for this, obviously. So like any of you that have been working with Dr. Fisher at all, if you call in with a new or worsening symptom, you get to talk to me. And so, I mean, this list, you guys know. You're like, yeah, Tina, great. I already know all of those things on that list. But we're here for any of those things. And I also realize that each one of you is so different and specific. So a nurse should be assessing you for you and your specific needs, and it's going to change depending on the day or the week, or sometimes even the season. With Raynaud's, we're heading into winter, and that might be the bigger issue. Whatever it is, nurses, we're here to assess whatever it is that you have going on. So phone triage is one of the biggest things that we do. And the reason I put that top one on there is answer questions. No question is too small. I always tell my patients, do not suffer in silence at home and sit and wonder. I want you to give me a call. Even if it's something so simple and it only takes us a 5-second phone conversation, I'd rather have you call and get that stress and that worry out of your mind and be able to answer that question, hopefully, than have you sit at home and wonder. And so we're here to assess new and worsening symptoms, help you kind of figure out, okay, do we need an urgent visit in clinic? Do you need to go to the emergency room? What is it that we need to do? Or what can we try at home? And then kind of follow up based on that. And then as nurses and myself in our clinic, I help you follow up on the treatment plan that's been created during your clinic visit. So if a GI referral has been placed or a referral to hand surgery, whatever it may be, I kind of help get those things in place. A lot of medications require lab monitoring. So I sometimes call myself the lab nag. So if I don't see that you've had labs done, you get a really great phone call or an email from me saying, hey, remember those labs you're supposed to have? Sometimes it's like Santa Claus. I have a list. I check it twice. You're either on one side or the other. So, and then results. Obviously, we realize that we do a lot of testing. We do echoes, we do pulmonary function tests, we do CT scans, we do all kinds of stuff. And then where My Health Connection is a wonderful thing, because you can access your results right away, or any other online portal in different systems, it is a wonderful thing, but it doesn't explain the results. So if you have anything that looks abnormal, all you see is that it's abnormal. And so I or other nurses are here to help kind of give you, okay, yes, it may be abnormal, but it's normal for you. Or, hey, this is unearthed something else, and this is what we need to follow up on. Or everything looks stable and great, and those are my favorite phone calls. So, and then getting messages to your providers. So sometimes I call myself the gatekeeper, sometimes because it's hard to get access to them because they have busy clinic days, they're traveling, they're, doing all these different things. But we, a lot of times, have ways to get a hold of them that are really quick, and we can help get answers to you guys in a really fast way. Navigation, again, which is, I think, is just a big piece of helping you guys figure out, okay, so during the clinic visit, we've decided that we put 6 different referrals in, we give you the phone numbers, and then we kind of send you out to the checkout desk and say, go figure that out. So that's where, in our clinic, where I come in, and in your other clinics, that's where your nurse comes in to kind of help navigate those and coordinate appointments across specialties. If you're coming from out of town, use your nurse as a resource to, if you can kill all birds with one stone and get all of those appointments on one day, or one day and stay overnight and get a couple more done the next day, use your nurse as that resource. And we also can help with insurance issues. And then, we're there to help get the right people involved to make sure that things happen and make your clinic and your kind of medical experience a little bit easier. And so care coordination is really big in what we do. Durable medical equipment. So if anybody has ever had to wear oxygen or, has ever had the need, then We are also, that's where we come in, because we know how to make sure that you're meeting insurance requirements. We know how to make sure that you're getting the right testing, getting you set up with oxygen that potentially is not going to limit your life as much as you think it will. So not having to carry around big tanks, or making it possible and feasible for you to travel by air, all different kinds of things, or other durable medical equipment. So you need walker, wheelchair, whatever it may be. I mean, anything that's going to make your life easier, we're going to help try and figure out how to get you that at home and make sure that it's covered by your insurance. And hopefully, if we can get it at little or no cost, then that's what we're going to go for. And an advocate. So this is one of the biggest reasons I got into nursing, is to advocate for people, to make sure that your voices are being heard. Sometimes I feel like, you come to a clinic visit and you have all kinds of information just kind of thrown at you. And then you kind of sit there. It's almost like being like a fire hose sometimes, especially in the initial phase. You've got everything coming at you, and you don't often have the option to share your opinion and share your voice, and that's where we're here to help with that as well. Here to advocate to make sure that you get everything that you need, whether it be at home, whether it be during the clinic. Get your messages across, get your goals for what you want your life to look like with this disease to the providers, to the powers that be, and to be essentially a sounding board. So like I said before, no question is too small. You can always call a nurse and ask. And if you need a nurse to advocate for something, that's a huge, huge part of our job. And I know all the nurses that I work with, that's what we want to do. We're here for you guys. We're here as your resource. And we want to be a resource that has no barriers, essentially, for you. I just flew through that. So does anybody have any questions? Nope. Sandy.
So what is respite care then? What's the difference between respite care and palliative care?
Yep, so respite care is typically for patients, like I said, if you have a patient that's typically homebound, and you have a caregiver, especially that, they either can't be left or the caregiver is worried about leaving them for whatever reason. If you have a patient that's, on high oxygen flow, you have a patient that is physically debilitated as far as walking. Walking's really difficult. They're worried about falls. There are organizations who provide respite care either in the home, or they provide respite care at an actual facility. So if, we have some patients, like family members, especially in the pulmonary clinic, that they can either take that patient there for a little while, or someone will actually come to their house so that the caregiver or family member can, whatever it may be, do stuff around the house. You need to do laundry, you need to clean, you need to run out, you need to run errands, you need to go to a doctor's appointment yourself. It just provides care for a short period of time so that the caregiver can get out of the house and take care of some things that they need to, but know that that patient is taken care of.